frequency are elevated to a much higher level in the acuity and the chaos of a code situation. Therefore, the Allina in-house resuscitation program is not meant to teach point-of-care ultrasound, nor is that the goal of this brief presentation. I'm going to give you a general understanding of the role this invaluable tool can play in the unstable encoding patient when it's in the hands of a highly trained provider, and why this tool is essential to providing the highest level of patient care and safety to some of our sickest patients at Allina. Many types of coding patients can benefit from the knowledge obtained from point-of-care ultrasound. However, we're going to focus the use within some specific type of coding patient where we potentially have the greatest impact on patient outcomes. We would look at patients in a PEA arrest. Even more specifically, we would look at patients within a sinus tach PEA arrest, which, as you know, is frequently just a continuum with very hypotensive patients. This set of patients frequently has a set of conditions that are treatable in many circumstances, but will kill them if not identified quickly and intervened upon. The pure mechanics of ultrasound image acquisition can be really difficult amongst a crowded bedside with compressions underway. However, when the team's adequately trained, quick ultrasound integration into a code is feasible both during compressions and at pulse checks without a significant delay in compressions. While there's no specific order that has to be followed for code ultrasound, there's a bunch of different protocols that exist in the literature and in practice. There is usually a logical progression that frequently makes most sense in the arresting patient. This guide on the left and the same guide that's found in the team leader card attempts to uncover some rapidly treatable and reversible causes of the code first and then move into the more nuanced etiologies. At the start, though, is IV fluids. And IV fluids are typically beneficial to all patients in PEA arrests initially, especially those in sinus tach PEA arrests. Even etiologies of PEA that involve elevated right-sided pressures, such as tamponade or PE, are typically benefited in the initial phase by fluids. So, going down, next we're going to look at the lungs. And this can be done at any time during compressions or at a pulse check as long as the patient is being ventilated. And that's the really important key here. The patient has to be being ventilated for lung ultrasound to make sense. The lung ultrasound finding to know as a member of the code team is called lung sliding. And these two images on the right show the ultrasound that's obtained when the probe is positioned as it's shown in this picture here. They show lung sliding, which is really the movement of two pleural surfaces on each other. One pleural surface, which is attached to the outside of the lung, and then this pleural surface is moving back and forth on the other pleural surface, which is attached to the inside of the chest wall. And this happens as the lung inflates and deflates during ventilation. The top image here is shown with a high-frequency linear probe. The probe is right here, and this is looking into the chest. This is the chest wall, the muscles. This is a rib, and this is another rib. And then just below the ribs, this bright white line here are the pleural surfaces moving back and forth on each other. That motion back and forth here is called lung sliding. Down below, you'll see the same patient just with a different type of ultrasound probe. This is a phased array probe or a cardiac probe, a little lower frequency. And this is the chest wall from here to here. And then this bright white line is lung sliding. These are the pleural surfaces going back and forth. You can see the movement there that exists in lung sliding. The presence of lung sliding is often obvious, but sometimes can be really difficult to convincingly identify. However, if lung sliding is present in the non-gravitational thorax fields, such as in the front of a chest on a patient who's laying on their back in a code, it 100% rules out pneumothorax at the site of insonation. For most code situations, that's what we care about. We care about large hemodynamically significant pneumos that should be present with a screen along the anterior midclavicular line, as shown in the image. Could they have a small pneumo loculated somewhere in the back? Yes, for sure. But we don't really care about this in the situation most of the time. So the presence of bilateral lung sliding rules out attention pneumothorax as the etiology of our narrow and fast PEA arrest. Ruling in a pneumothorax is a little bit more difficult of a task with ultrasound. The lack of lung sliding is the finding that's present in pneumothorax. And you can see that in the upper left-hand image here. Here is the pleural line right here. So this is the chest wall again. Here's a rib, the cortex of the rib, and another rib. So this is that pleural line that looks like a very still, nicely drawn white line, compared to over on the right side here, the normal one, where you see movement back and forth along that white line. In addition, the reflection below this white line is a really beautiful reflection of what's up above it, compared to sort of this, looks like a old black and white TV that got unplugged, kind of noise on this right image. So this is what pneumothorax looks like, a lack of lung sliding and typically a pretty reflection below that white line of what is up above. However, there are other reasons that the visceral and the parietal pleura might not be sliding back and forth on each other. You can probably think of a few, but at least a couple on the list are: take a patient who's had a pleurodesis, where these two pleural layers are fused together, and they're just not going to slide because they can't. Or you intubate a patient in a code, and they don't have lung sounds on the left side anymore, and you look at their left chest, and there's no lung sliding there, but there is on the right. This is what a right main stem intubation looks like, because if you're not ventilating the left lung, the pleural sliding is not going to be present. Likewise, someone who you're really worried about a pneumo in because they've got bad emphysema, big bullous emphysema, and you intubate them and then they code. If you put your probe right over a giant bullae on a patient with emphysema, that bullae doesn't move much as you ventilate, and you might not see the lung sliding when you're directly over a bullae. So the lack of lung sliding is what you would find in a pneumothorax. However, this does not 100% rule in the presence of a pneumothorax. It may, however, be adequate in the right clinical scenario to intervene with a needle thoracostomy or a chest tube placement based on that finding alone. So how do we get all the way to 100%? Yeah, that's a pneumo. And the term here that you need to be aware of is a lung point. And if you look at this CT image up at the top here, the lung point is the point right inside the chest wall here, where pneumothorax, the black area, meets lung. And right here, you would see the lung sliding, where the lung is up against the inside of the chest wall. And over here, you wouldn't. And the alternation of lung sliding with pneumothorax, a really pretty reflection of what's up above, is called the lung point. And here you can see in this bottom image moving left and right on the screen as the pneumo coming in and then going out, comes in and out here. So this is lung over here on the right side up against the chest wall, alternating with air coming in from the left side. And this is the lung point. And this is 100% pneumothorax, unless you're mistaking this for something else, but the lung point is the way to rule in a pneumothorax. All right, after we've ruled out a pneumothorax with lung sliding bilaterally, we're going to try to rule out tamponade as a potential etiology for our PEA arrest. And from a cardiac window standpoint, your parasternal window here is usually occupied either by Lucas or by someone's hands doing chest compressions. The traditional spot to get a cardiac view in a code would be the subxiphoid window right here above the belly button, below the rib cage. But with Lucas running, this can actually be a tough spot as well, because things are moving quite a bit here, and sometimes the apical window is out of the way, and you can get in here with Lucas running, and this is actually a pretty stable part of the chest to obtain a cardiac image. What we're looking for is pericardial effusion, and sometimes they're obvious. Here is a heart, and black is fluid on ultrasound, so this large black stripe here around the heart, this is a parasternal window, is a large pericardial effusion with a heart that's swinging in this bag of water. Here is a subxiphoid window, looking through the liver here with a pericardial effusion as well, and a small right ventricle. Here's another zoomed out subxiphoid window. This big stripe here is pericardial effusion. And then here is a window from out at the apex of the heart, underneath the left nipple. And here you can see a heart swinging back and forth amidst a big balloon here of black fluid, and that is a large pericardial effusion. So tamponade is a clinical diagnosis. The presence of pericardial effusion on ultrasound is one step to that, but is really a clinical diagnosis. All right, moving south on this list, we've ruled out a couple things that are intervened on with a procedure. And now we're going to look at the tank, if you will. How full is the tank? Is this patient in hypovolemic shock or vasodilatory shock? Do they need volume, volume, volume? And we started off with volume, so it's already running at this point. But this gives us some clues. And up at the top here, this black tube is the inferior vena cava coming through the liver and emptying into the right atrium, which is right over here. And this is a nice normal looking inferior vena cava. Its size, it kind of collapses when you take a breath in. Down here, this is a totally flat inferior vena cava. This tube here in long axis is hardly ever visible. And this is a very flat IVC. Here's that tube in cross section. This little eyeball that's winking at you just barely there. So this is a flat IVC. This goes along with a low right atrial pressure, and this is a clue that you are in a vasodilatory or a hypovolemic state. This could be hemorrhagic shock, this could be sepsis, but this is going to give you more push towards aggressive volume resuscitation. If it's not flat, here's another example of flat in the upper left here, where this little tube every once in a while appears, but otherwise is totally void of fluid. And here's a normal IVC. And then if you make this even bigger, you end up with this nice big fat tube here with some hepatic vein dilation. And this is an elevated right atrial pressure state with a distended inferior vena cava. This might mean volume overloaded, or it might not, but it just means that the pressures in the right atrium are elevated. In and of itself, the dilated IVC should not mean that you need to stop volume resuscitation, as there are clinical entities such as tamponade that have dilated inferior vena cavas and actually benefit from IV fluid and increased preload. Last on this algorithm is an assessment of cardiac function, and this is a global eyeball of how well is this heart doing. And at the start here, this is about left ventricular systolic function. So here is a left ventricle, this donut here, squeezing quite well and tachycardic. This is a normal functioning left ventricle that's tachycardic. And then contrast that to the tough window where we're missing some of that donut because it's a little bit big. But this left ventricle here, the donut is not squeezing normally. This is a severely reduced systolic function compared to a normal tachycardic systolic function. This is the parasternal short axis. So decreased LV systolic function was due for us in the code. If it's not expected, it gives us some insight into potential etiologies. And if it is expected, it's got to be combined with other things. Let's go over here to a subxiphoid window. And here's a left ventricle in the subxiphoid window that's functioning normally. The two walls coming together. And here's a left ventricle down here that is hyperdynamic, that's empty. That may benefit if this was a hypotensive patient with a flat inferior vena cava who was really hypotensive such that you couldn't feel a pulse and you called this PEA, sinus tach. This is probably just really hypotensive sinus tach. And this heart here would benefit almost for sure from a fluid bolus in these patients. So the spectrum of LV systolic function, when integrated with what we talked about previously, assessment of the right-sided pressures with the IVC, and then with lung findings from pulmonary edema, etc., can be a really valuable third piece to this assessment, but should come a little bit later. Finally, an assessment of the right ventricle, which is a advanced point-of-care ultrasound entity, and is very difficult to do even on formal echo to try to get your head around how well is the right ventricle functioning. So what we're really looking for at this phase is a significantly dilated right ventricle in a patient in a sinus tach PEA arrest. So down here at the bottom, here's the left ventricle. And here, this smaller shark-finned chamber is the right ventricle, and the right ventricle should be smaller than the left ventricle. Up here at the top, this is a PEA arrest in a postoperative patient, and here the right ventricle is bigger than the left ventricle, and this is a dilated right side in a massive pulmonary embolism. So while difficult, the obviously enlarged right ventricle that shouldn't otherwise be there from some other history component from their past, this can be extremely helpful in an otherwise undifferentiated code situation. All right, let's finish this off with a quick case